For patients with localized pancreas cancer, so patients who actually undergo surgery, Whipple or pancreatectomy, and those patients, once they come out of surgery, we have data, we have had data for at least a couple of decades, 2 to 3 decades actually, that suggest that giving those patients or exposing them to adjuvant therapy makes a difference. So we know that those patients would benefit from treatment. Then the next question was, what kind of treatment? So the first question was chemotherapy versus chemotherapy and radiation. And so we have one study from the early 2000s that suggested that chemotherapy helps, whereby chemotherapy and radiation may be detrimental, although that study had significant limitations. Historically, though, when we look at the value of adding radiation to chemotherapy in pancreas cancer, it just does not seem to add value versus chemotherapy alone. So at least at this point of time, outside of a clinical trial, it seems like it makes most sense to apply chemotherapy only for 6 months and leave radiation as a experimental question, meaning in the confines of a clinical trial, which is being done by Energy RTOG, looking at the question of whether we give chemotherapy for 5 months and then apply radiation with chemotherapy for patients who do not progress. That question is still being asked in the experimental setting. Outside of an experimental setting, I believe that patients, regardless of resection margin or lymph node status, should receive adjuvant chemotherapy, no radiation. And the next question is, which chemotherapy regimen? There's gemcitabine alone and 5-FU. Gemcitabine alone seems to have activity. 5-FU seems to have very similar activity. Although, because the study included only bolus 5-FU, there seems to be added toxicity compared to gemcitabine. So right now, the preferred regimen would be gemcitabine alone. So the next question, of course, is, can we do better than what we have right now? Right now, we doubled the disease-free survival of patients. We improved a little bit the overall survival with giving chemotherapy. And the question that remains is, of course, can we do this better? So there are two strategies, actually 3 strategies, that are asking the question. One, unfortunately, seems to have failed, and that adding an immune therapy, a vaccine, a hyperacute vaccine, L-Gempenticel-L, to chemotherapy or chemotherapy and radiation. We heard, at least from the press release from the study called IMPRESS was negative, so failed. The second strategy is to actually add nab-paclitaxel to gemcitabine versus gemcitabine. So try to simulate the improvements we've seen in the metastatic setting and see if we can bring those to the localized setting. This study has completed, and we're waiting for the final results. We've heard that SPEC-4, which is a study that was conducted in Europe, looking at gemcitabine versus gemcitabine and capecitabine, is actually positive, at least statistically positive. We haven't seen the results yet to make our mind up whether it's clinically meaningful or not, but at least statistically there has been an improvement. So it seems a strategy of building up on gemcitabine with another cytotoxic agents may actually improve outcome in that disease. And finally, there's a study with FOLFIRINOX versus gemcitabine, which may provide us also some answer about whether a triplet would actually even add more value. But we'll see. That study's results are far from being obtained at this point of time. So we have a number of strategies that are being looked at in the localized setting.